مساء الخير. أهلا وسهلا بكم في هذا اللقاء، وهو بعنوان Clinical Aspects of CITALOPRAM. يقدمها الأستاذ الدكتور نزار محمد أمين، أستاذ الطب النفسي في السليمانية كردستان العراق، وهو من أعلام الطب النفسي المعروفين في المنطقة. تفضل دكتور نزار.
شكرا جزيلا دكتور وليد. طبعا كالعادة أخجلتم تواضعنا. جميل جدا أن نلتقي مجددا بعد انقطاع، وأتمنى أنه الكل يكونون بصحة جيدة وبسلام وأمان وبعيدين عن كل المشاكل. Tonight we will talk about a drug called citalopram, which everybody I'm sure knows, but I'll talk more about the clinical or practical aspects of this drug. Most of my presentation is taken from a book from Professor Stahl, and really I would like to start by saying we say that citalopram belongs to a group of drugs called antidepressants. But I wonder whether that's a suitable term, antidepressants, for a simple reason that there are other drugs which are used for treatment of depression. Therefore, just leaving a name of antidepressants to this group of drugs is not really a practical point. And also another point is that these drugs are used for treatment of other psychiatric disorders like anxiety, eating disorders, etc. For that reason, again, just calling them antidepressants is not enough. And of course, another reason is that there are other drugs that are used for treatment of depression, for example, antipsychotics. Therefore, just restricting the name of antidepressants on this group of drugs is not a good thing. Therefore, the modern neuroscience-based nomenclature is a better terminology, and I'll talk about it in a couple of slides more. Right. Now, citalopram is commonly prescribed for depression. However, it's also used for premenstrual dysphoric disorder, OCD, panic disorder, generalized anxiety disorder, PTSD, and of course, a social anxiety disorder. Now, according to the neuroscience-based nomenclature, it's better to call them or call it the citalopram serotonin reuptake inhibitor, or selective serotonin reuptake inhibitor, or a specific serotonin reuptake inhibitor, often classified as an antidepressant, but of course, it's not just an antidepressant. Now, how does this drug works? Of course, it works mainly on serotonin, and it blocks the serotonin reuptake pump, and it desensitizes serotonin receptors, especially the 1A autoreceptors. It also has mild antagonistic action at H1 receptors, and this is important for the side effects of this drug that we will talk about it. It has an inactive R enantiomer that interferes with the therapeutic action of the active S enantiomer at serotonin reuptake pumps. Now, we all know that serotonin and the rest of the SSRIs takes at least 2 to 4 weeks to work. And this is one of the problems that we face when we treat our patients, especially uneducated patients who will come back to you in a week time and ask you to change the drug because it didn't work. But the practical thing is that you have to wait for 6 to 8 weeks. If it didn't work, then it might need increasing the dose, or this means that it is not working at all. In both cases, if it works, it may continue to work for many years to prevent relapse of symptoms. Now, what if it doesn't work? Even after 6 to 8 weeks, the drug did not work. In that case, we have to be careful, but at the same time, we have to know that sometimes citalopram treats the depression, the depressed mood, but there are other symptoms of depression that might not improve with citalopram. For example, insomnia, fatigue, and difficulty in concentration. Also, some patients who do not respond are called treatment resistant or treatment refractory patients or treatment refractory depression. Also, another problem with this citalopram is that there is this phenomenon of poop out, which means that the drug works at the beginning, but later on it stops working. It's just like the burnout that we get when we are dealing with our patients. We are very active at the beginning, but later on, because of burnout, we stop being active and we stop looking after our patients as we used to do. Now, if it didn't, the patient did not respond, increase the dose or switch to another agent or add an appropriate augmenting agent. It is nice to remember that when I was a trainee psychiatrist in the 70s, I had one of our seniors, rahmatullahi alayhi, Dr. Zuhair al-Mukhtar. He said that when I was training in the UK, our professor said, if the patient did not respond, think of 3 Ds: dose, diagnosis, and duration. And of course, this works until today. Now, if it didn't work alone, consider psychotherapy, consider the presence of other comorbid conditions, and also, of course, substance abuse. And I could add to Professor Stahl's point here, many times we miss personality disorder. We treat the patient properly, but we forget about the accompanying or underlying personality disorder. That's why when DSM-5 removed the multi-axial classification or whatever it was called, I think it didn't do a good thing by forgetting about the underlying personality of the patient. Sometimes patients might experience apparent lack of consistent efficacy. And this is either because the patient has switched to mania and the patient has really bipolar disorder, or in this case, of course, we have to discontinue antidepressants. Although there are some people, and probably maybe we are part of those people, whom we think if we suspect that the patient has bipolar depression from the beginning, even if it is the first episode of depression, that is when the patient is very young, if the patient is not responding to antidepressants, and if the patient has other features that indicates the bipolar, it is better to avoid antidepressants. Anyway, practically, sometimes this is not easy to do. Now, the augmenting combos for partial response or treatment resistance are the following: trazodone for insomnia, bupropion, mirtazapine, reboxetine, or atomoxetine, and also sometimes combinations of antidepressants with caution should be used because this may activate bipolarity, and of course suicidal ideation. But of course this is a controversial issue, although the end point is used with caution before the age of 24, and also try to report and record everything, every aspect of the use of this drug. Now, modafinil, especially for fatigue, and if the citalopram is causing sedation or sleepiness and lack of concentration, is useful. Now, mood stabilizers or antipsychotics, especially if the patient has bipolar depression, psychotic depression, or treatment refractory depression, or if the patient has anxiety with it and the anxiety is not responding. Of course, benzodiazepines for a short period of time, and if all fails for anxiety disorders, consider gabapentin and tiagabine. I do not prefer them, but of course I have to mention them. Of course, hypnotics for insomnia, and classically, lithium, buspirone, or thyroid hormone could be used again as augmenting agents. Now, Professor Stiles said how drug cause side effects. I do not prefer the word side effects. I prefer unwanted effects. So how does it cause these unwanted effects? It acts on these unwanted effects are due to the effect of serotonin at sites other than the sites which are therapeutic. For example, effect of serotonin in sleep centers causes insomnia, or in the gut leading to diarrhea, and of course in other places. Now, increasing serotonin can cause diminished dopamine release and might contribute to emotional flattening, cognitive slowing, and apathy in some patients. That's why some of intelligent patients, especially well-educated patients, and I'm sure all of you have faced this problem, will come back to you after 2 or 3 months and tell you, thank you, doctor, my depression disappeared, but really I am a different person. I have no emotions, I have no reactions, and I don't care. So of course, this is one problem that we face when we are dealing with our patients who are treated with SSRIs in general, and in this case, citalopram. We have most of these. It is worth mentioning that unlike the therapeutic effect of citalopram, which appears late, the side effects appear very early in the treatment. And of course, this is another problem that we face. A patient comes back to you after 3 or 4 days or 7 days, tells you, دكتور انت قتلتني، أنا ما أتحمل بعد هذا الدواء هيك سوى بي. He is right or she is right, but we have to convince them that these are unwanted effects. They disappear with time, and later on, the payoff is when you start feeling the therapeutic effect of citalopram. And of course, among them is the mild antihistamine properties, which leads to sedation and fatigue in some patients. Among the unwanted effects, we have sexual dysfunction, and it is dose dependent. In men, there will be delayed ejaculation with erectile dysfunction, although some men like it, and the patient comes back to you and tells you, doctor, I have to tell you, it is causing this. I enjoy it, I like it, but I have to tell you that it is causing this. For both sexes, both genders, there will be decreased sexual desire and anorgasmia. Of course, gastrointestinal symptoms, and of course, other CNS symptoms include insomnia or sedation, agitation, tremors, and this is a problem really with some of our patients, especially highly sensitive patients, those who have some jobs that requires concentration and requires stable hands. This is a problem for them. Now, of course, switching to mania, that's to say activation. And of course, this is problem, especially with bipolar depression and with patients with psychotic disorders. Sweating, which is dose dependent, bruising and rare bleeding, and in elderly people like us, hyponatremia. But of course, it's a temporary phenomena. Once you stop the drug, it disappears. And another problem is the syndrome of inappropriate antidiuretic hormone secretion. Now, some dangerous or life-threatening unwanted effects include seizures. This is very rare. Rare induction of mania, rare activation of suicidal ideation and behavior, that's to say suicidality, and short-term studies really reveal that it's not that strong, but it is better to be safe, to avoid it and use it beyond the age of 24. Weight gain is one of the problems, although we don't expect it. And again, it is related to the histamine, or probably the patient does not move a lot and so on. There will be weight gain or weight loss in some studies, but really most of the cases they are weight neutral. Other SSRIs might increase weight, but for this one, it's not to that extent. Now, sedation in a minority of people. Now, how do we deal with these unwanted effects? 3 times weight. Yani weight, weight, and weight. And I've used this policy with most of my patients, and most of them come back later on and tell me, thank you, doctor, for telling us about this. We've waited, and the payoff was that we got better, and most of the symptoms of the unwanted effects disappeared. If there is insomnia, take it in the morning. If there is sedation, take it at night. But if it didn't work and the patient cannot tolerate it, you have to switch to another drug. Now, sometimes you might need to try another SSRI. Some people might say, well, this is the same group. Why do you use a different member of the same group? Well, practical experience and many of the literature supports the notion that sometimes if you just change the individual SSRI, the patient will respond. Now, trazodone or hypnotic for insomnia, bupropion, and tadalafil for sexual dysfunction, and bupropion for emotional flattening. That's to say, if you combine citalopram with a bupropion, probably you will avoid the emotional flattening and the cognitive slowing and apathy that I mentioned a few minutes ago. Now, mirtazapine is useful for insomnia, agitation, and for gastrointestinal side effects. Benzodiazepines, and by the way, this initial jitteriness is sometimes very, very annoying to the patient. And when the first time we saw Prozac, that was, I think, in the 90s. I cannot remember the exact date. It was the first time in my town. At that time, I was working in Erbil, not in Suleymaniye. I gave one of our medical assistants who developed depression fluoxetine. And he came back to me after 2 days. He said, I cannot stand still. I have a problem keeping myself quiet and stable and so on. But later on, after a few days, he got better. So benzodiazepine is useful for initial jitteriness, and many of the side effects of SSRIs in general are really dose dependent. If you reduce the dose, provided that the patient will not relapse, they get better. And many of them, as we said, it is time dependent, and they start immediately, but they disappear. And agitation means, or activation, it could be beginning of bipolarity. So be careful in these cases. And sometimes either you have to stop the drug, or you can add lithium or a mood stabilizer, another mood stabilizer, or an atypical antipsychotic. The dose 20 to 40, and forms, these are the forms which are available: 10 milligram, 20 milligram scored, and 40 milligram scored, or in a solution of 10 milligram per 5 ml. How to dose? You start initially with 20, and then you can increase it after a few days. Let's say after a week to 40 milligram, which is maximum dose. And it could be taken either in the morning or evening, according to the response of the patient and whether it is causing sedation or insomnia. Some tips: citalopram should no longer be prescribed at doses greater than 40 milligram per day, because there will be problems with conduction defects in the heart. And there is some controversy with FDA dosage limits of 40 milligram. Tablets are scored, so to save cost, of course, you can give the patient 20 milligram tablets and ask him to take half of the tablet and so on. Now, many patients respond better to 40 than 20 and give it once a day. And we said about the time. And also, if there are intolerable anxiety, insomnia, agitation, or akathisia, which is very rare, but it could happen, or activation upon either dosing initiation or discontinuation, consider the possibility of activated bipolar disorder. Right. In overdose, rarely there will be fatalities if it is taken alone. Vomiting, sedation, heart rhythm disturbance, dizziness, sweating, nausea, and tremor. Rarely there will be amnesia, confusion, coma, and convulsions. With long-term use, it is safe, and it's not habit-forming. And we know, all of us agree, that if the patient is taking this drug for the first time, then you can give it for 6 months, for example. If it is after the first time, probably the patient needs it for 1 year or more. And if it is more than that, and I'm sure Dr. Walid agrees with me, then you should give it for life. Professor Stahl says tapering is not necessary. I don't agree. I personally feel that most of my patients, when I start reducing the dose, when they get better, they develop what we call discontinuation symptoms. I don't call them withdrawal symptoms. So it is better to taper slowly. And recently there was a book from the Mosley called Mosley Unprescribing Guidelines, or deprescribing guidelines, and they insist that the tapering should be done, and should be done very, very slowly, especially when you reach the very small doses of all the drugs, all the antidepressants that we use. However, tapering to avoid potential withdrawal reactions, generally prudent. Now, if withdrawal symptoms emerge during discontinuation, raise the dose to stop symptoms and then restart slowly. Right. Now, the pharmacokinetics, it has a long half-life. That's why it is used once daily. And please remember this effect. It's a weak inhibitor of CYP2D6, because in a few more slides, I'll talk about that. It is metabolized like other antidepressants with CYP3A4 and CYP2C19. Interactions. Tramadol increases the risk of seizures, and it can increase the tricyclic antidepressant levels. Therefore, use with caution with these drugs. And it can cause fatal serotonin syndrome when combined with MAOIs. So please do not use with MAOIs, or at least for 14 days after the MAOIs are stopped. Do not start a MAOI for at least 5 half-lives after discontinuing citalopram. So if you stop MAOI, you have to wait for 14 days. If you stop citalopram, you have to wait for 5 to 7 days. May displace highly protein-bound drugs like warfarin, and can rarely cause weakness, hyperreflexia, and incoordination when combined with sumatriptan, or possibly other triptans, requiring careful monitoring of the patient. Now, possible increased risk of bleeding, especially when combined with anticoagulants like warfarin, I've just said warfarin, and non-steroidal anti-inflammatory drugs. These NSAIDs may impair effectiveness of SRI. Of course, they act on each other. It should not be dosed above 20 milligram in patients taking CYP2C19 inhibitor, like cimetidine, due to the risk of QTC prolongation. And of course, this is important for gastroenterologists who are using sometimes antidepressants for their patients. Unfortunately, most of our patients are daily visiting clinics of other specialties. Among them are the gastroenterologists, and our colleagues in the gastroenterology department tell us that if we stop or if they stop seeing those kinds of patients, they will go bankrupt. Therefore, they will continue seeing them. Now, via CYP2D6 inhibition, I've just mentioned this before, it could theoretically interfere with the analgesic action of codeine and increase plasma levels of some beta blockers and atomoxetine. And via this action also, it could theoretically increase concentrations of thioridazine, although thioridazine is no more used, but I know that there are some colleagues in Baghdad that are still using it, and it caused dangerous cardiac arrhythmias. Right. Now, use with caution in patients with history of seizures, use with caution in patients with bipolar, and when treating children, carefully weigh the risk and benefits of pharmacological treatment against the risks and benefits of non-treatment, because sometimes really you will feel sorry if the patient develops problems because you avoided using this drug. Distribute other warnings, distribute the brochures provided by FDA, etc. And of course, you have to record everything. You have to record that you have told the parents of the child about the risks of this drug and so on, and you have taken their at least verbal consent. Do not use if the patient is taking MAWI or if the patient is taking thioridazine or pimozide. For those colleagues who haven't seen pimozide, it has another name, ORAP. It was used when we were younger for monosymptomatic hypochondriacal psychosis, and it was very effective. Then it disappeared from the market and then reappeared again. And some people use it nowadays for delusional disorder. If there is a proven allergy to citalopram, of course, you have to avoid it. Citalopram and even escitalopram, because it seems to me that there is cross allergy. For renal impairment, mild impairment, no problem. But for severe impairment, we have to be cautious. For hepatic impairment, should not use greater than 20 milligram per day. And of course, you have to be cautious about maximum tolerability. For cardiac impairment, we've just said that it could lead to cardiac rhythm abnormalities. Therefore, be careful, do not use a high dose. And especially when you are combining it with cimetidine, treat depression with SRI in patients with acute angina or following myocardial infarction. This is important. It may reduce cardiac events and improve survival as well as the mood. And this is either a direct effect of the citalopram itself on the heart, or probably you are treating the stress and the problems the patient faces when he develops these ischemic heart problems. So it helps them cope with these problems. For people like us, the elderly, we should avoid doses greater than 20 milligram, although really sometimes some patients need a higher dose, but of course you have to be careful and monitor the patient very carefully. Risk of symptom of inappropriate antidiuretic hormone secretion with SSRI is higher in elderly, and citalopram may be an especially well-tolerated drug in elderly, and reduction in the risk of suicidality and antidepressant with antidepressants compared to placebo in adults age 65 and older. So it is useful really in the elderly people. As far as children are concerned, here it is a bit tricky. You have to be careful in using it with them. And of course, you have to record everything. And sometimes the benefit of using the drug is much greater than the risk of using the drug. Monitor the patients face-to-face regularly, especially at the beginning of the treatment. Use with caution when there is risk of activation. I mentioned at the beginning that in young patients, presence of depression sometimes is the beginning of a bipolar depression. So be careful of this problem. Not specifically approved, but preliminary data suggests citalopram is safe and effective in children and adolescents with OCD and with depression, of course. For pregnancy, it's a controversial. There are different opinions, but it acts on pregnancy, but at the same time, the control studies have not been conducted in pregnant women. Now, not generally recommended for use during pregnancy, however, especially, during the first trimester. Nonetheless, continuous treatment during pregnancy may be necessary. And if the patient is already on this drug and she becomes pregnant, it is better not to stop it if there is a risk of relapse, and the relapse will lead to a lot of problems. And at delivery, there may be more bleeding in the mother and transient irritability or sedation in the newborn. But at the same time, again, if you stop it, there might be a lot of problems. And we are all aware of the possibilities of postpartum hemorrhage, of postpartum depression later on. We must weigh the risk of treatment against no treatment, and which leads to recurrence. And for many patients, this may mean continued treatment during pregnancy. Exposure to SSRIs early in pregnancy may be associated with increased risk of septal heart defects, but the absolute risk is small. And SSRIs beyond the 20th week of pregnancy may be associated with increased risk of pulmonary hypertension in newborns. Of course, this is more with paroxetine than with citalopram. Although this is not proven, exposure late in pregnancy may be associated with increased risk of gestational hypertension and preeclampsia. But of course, with proper monitoring, you will avoid these problems. Neonates exposed to SSRIs or SNRIs late in the third trimester have developed complications, required prolonged hospitalization, and these are reported symptoms are consistent with either a direct toxic effect of these drugs or possibly a drug discontinuation syndrome, and include respiratory distress, cyanosis, apnea, seizures, etc. Right, breastfeeding. This is a very, very common asked FAQ, frequently asked questions. Some drugs, some of the drug is found in the mother's breast milk, but trace amounts may be present in nursing children whose mothers are on citalopram. If child becomes irritable or sedated, breastfeeding or drug may need to be discontinued. But keep in mind, if you stop the drug in a nursing mother, there is always a possibility of postpartum depression or puerperal psychosis. Now, especially if the patient has past history of this condition. We must weigh the benefits of breastfeeding with the risk and benefits of antidepressant treatment, various non-treatment to both the infant and the mother. Therefore, it is better for some patients, for many of them, to continue breastfeeding and use citalopram. What are the advantages of using citalopram in general? It is useful for elderly patients, patients excessively activated or sedated by other SSRIs. It is useful for those kinds of patients. And the disadvantages, they may require dosage titration to attain optimal efficacy, can be sedating in some patients, and the primary target symptoms are depressed mood, anxiety, panic attacks, avoidant behavior, and these are the symptoms that are really we have to target. Some pills, it may be more tolerable than other antidepressants, may have less sexual dysfunction than others, may be especially well tolerated in the elderly, may be less well tolerated than citalopram. Documentation of efficacy in anxiety disorder is less comprehensive than for citalopram on other SSRIs, and can cause cognitive and affective flattening. And we said if you add bupropion, you can counteract that effect. Some evidence suggests that citalopram treatment during only the luteal phase This is important and tricky when treating those ladies with premenstrual dysphoric dysfunction. You only restrict the supply of the drug to the luteal phase of the patient, provided that she has normal periods and so on. SSRIs may be less effective in women over 50, especially if they are not taking estrogen. It may be useful for hot flushes in perimenopausal women, and non-responsive citalopram in elderly may require consideration of mild cognitive impairment or Alzheimer's disease. Now, this is from the last edition of the comprehensive textbook of psychiatry. It says the cardiac effects of SSRIs in general include dose-related QTc prolongation. So this is really a warning. As far as breast cancer is concerned, while several studies have confirmed that antidepressant drugs have strong 2D6 inhibition, I've talked about that, and therefore they reduce the conversion of tamoxifen to the active metabolite. This effect is less with two drugs, venlafaxine and citalopram. So it is better to use these two drugs for patients with breast cancer who are on tamoxifen. I will not bother you with this, but this is a comparative study. Citalopram was more efficacious than paroxetine and reboxetine and more acceptable than tricyclic reboxetine and venlafaxine. These are my references. Thank you for your attention, and I'm ready to take questions after Dr. Waleed's comment. Thank you.
شكرا جزيلا على دكتور نزار كالعادة على هذا التقديم الرائع. والحقيقة هو مراجعة للSRI بشكل مميز وواضح. لابد من أن يعني التشديد على بداية نقطة الجرعة. يعني هناك تحذير من ال FDA بأنه ماكسيمم دوز 40، ومعظم الأطباء كون يعني بالدوزز من السهل عليهم أن يتعاملوا معها، نجدهم يعني إلى حد ما متساهلين في هذه الجرعات. ورأيت وصفات محطوطة ب40 مرتين باليوم، 40 3 مرات في اليوم. ولابد من الانتباه إنه يعني أخذوها على مبدأ سيرترالين 50 ممكن يصير 200، فلماذا لا يكون سيتالوبرام 120؟ الوحيد بين الSSRI اللي فيه مشكلة تحذير على البرولونجيشن اوف QTR انترفال هو سيتالوبرام. البند الآخر وهو موضوع الحمل والولادة والرضاعة. يعني الحقيقة ستال زي ما دائما المصادر الأمريكية تعطي تحذيرات مرعبة. لو فعليا بدنا نمشي على تحذيره يمكن ما عرفنا نعالجه ولا مريض. يعني في التسعينات لما كان تقريبا موجود سيتالوبرام وفيفرين وبروزع كنا نستعملهم بشكل يومي، ولم يحدث إن لاحظنا مثل هذه المشاكل. كل ما فيها من مشاكل بأنه أحيانا بعض السيدات بعد الولادة عندما يصبن بأي شكل من أشكال النزيف، فالطبيب النسائي لا يعرف ما هو الدواء، يذهب للبحث عنه فيجد أنه بزيد، فيقول له هذا النزيف بس من، يعني بمعنى أن لا يمكن تنزف السيدة حامل عند الولادة إلا إذا هي بتأخذ هذه الأدوية. فلا بد أيضا من الانتباه أنه هو ما بيسبب النزيف، هو إذا في نزيف قد يؤخر من تجلط الدم. الأمر الثالث واللي دائما يطرح عن الفرق بين سيتالوبرام والسيتالوبرام. طب ما هم نفس الموليكيول، هم مش نفس الموليكيول،
آه.
هم ار واس ايزومر. والاستيلوبرام يختلف بشكل بالانديكيشن والابروفل، ماخذ ابروفل على عدد من الديسوردر، بينما الستيلوبرام ماخذ ابروفل على الدبريشن. برضو التحذير في الاستيلوبرام أن لا تزيد جرعته عن 30 ملغ. يعني هذه ملاحظات عامة. نفتح المجال الآن للزملاء والزميلات لأي سؤال. تفضل، فرصة ثمينة أن يكون معنا أستاذ دكتور نزار للإجابة عن أي تساؤل عن سيتالوبرام أو عن الأنتي ديبريسنت عموما. دكتور جلال.
والله يا دكتور ما عندي، يعني أنا كان عندي تساؤل إنه اختيار السيتالوبرام مثلا بسوريا، بالحقيقة ربما يدوروا عليه الزملاء ما يلاقوه، لأنه الموجود هو الإسيتالوبرام.
صحيح.
اختيار الستيلوجرام يعني هيك كأنه طغى عليه الاستيلوجرام، خاصة انه
طبعا
صار
عليه بشكل كبير يعني. صحيح. هلا هم كلاهما يعني أنتجوا من نفس الشركة. يعني
امم
لوبك هي اللي أنتجت ستالوبرام في البداية. وفي وقت لاحق يعني هو وجدوا بأنه الآيزومر أكثر إفكتيف، نزلوا بدل سبران نزلوا سبراليك، اللي هو لحد الآن موجود وأصبح في منه آلاف الجينيركس في العالم. الواقع يعني من بدء من ما توفر الاستالوبرام أصبح يعني كتاب ستالوبرام نادر.
حتى لانه بالماركتينج تبعه صار في للاستيلوجرام على انه هو انتقائي اكثر للمستقبلات الدماغيه،
مم.
وبالتالي اثاره الهضميه راح تكون اقل،
مم.
لانه هو ليس يعني هو انتقائي اكثر. فصار يعني مثل حتى يعني ابتعاد عنه، اذا بينوجد فبيبتعدوا عنه الاستالوجرام لصالح الاستالوجرام.
شو رأيك دكتور نزار؟
والله طبعا شكرا دكتور جلال على السؤال. أنا أتفق معك. الحقيقة نفس الشركة المصنعة أنا حضرت كم محاضرة لهم، يدعون بأنه الإيسيتالوبرام has more rapid action. يعني صح احنا ننتظر 2 to 4 weeks but escitalopram works faster earlier. بس مع ذلك أنا أعتقد أنه both of them are effective، واثنينهم يشتغلون. بس يعني كل واحد منهم يشتغل على قسم من المرضى وما يشتغل على المريض الآخر. وإحنا عادة بالبراكتس تبعنا نستعمل اثنينهم. صح نستعمل اسيتالوبرام أكثر من السيتالوبرام، بس مع ذلك الديلي براكتس تبعنا نستعمل السيتالوبرام وده يشتغل، ويعني تقريبا الإفكت سيميلر.
شكرا دكتور.
هو يعني أنا في عندي تساؤل دكتور نزار. مرت فترة كان في ادعاء بأنه السيتالوبرام مفيد في الألزهايمر. إلى أي مدى وجدت هذا مناسب؟
أبدا ما شفته مناسب. والحقيقة once Alzheimer occurs فما أعتقد إلا إذا المريض عنده ألزهايمر with depression، هذا شيء آخر.
لا، هم قالوا ألزهايمر حتى بدون ديبريشن.
إيه ما أعتقد very effective، وما شفت كثير literature على هذا الموضوع.
آه. لأنه لا زال يكتب صراحة
مم.
يعني بشكل غير منطقي من قبل بعض الأطباء لمرضى الدمنشيا وبيؤدي في كثير من الأحيان إنه المرضى يعني عندهم باثولوجي، عنده اسكيميك هارت وعنده أشياء كثيرة، ويضيف له جرعة 40 ستالوبرام يعني غير منطقية وغير مدعومة بإيفيدنس. كان صدر يعني 2-3 reports إنه it helps it helps symptoms of dementia وليس depression. على معروف إنه أي أنتي depressant يمكن الاستفادة منه خصوصا في الإيرلي dementia والdepression. برضو هذا يعني قد يكون البعض قرأ مثل هذه الريبورت إنه مفيد، هو الواقع يعني ليست له هذه الأهمية بأي شكل من الأشكال. ومفروض إنه يعني ما وجود كيس ريبورت أو سيريز أوف كيس الإيفيدنس، هذا evidence based medicine لا يقبلها. يعني يمكن البعض قد لا يكون على اطلاع بأنه يعني في مستويات ما يقبل في الإيفيدنس بيز، وهذه المستويات أضعفها هو الكيس ريبورت.
اصلا دكتور، بلا ما اقطع كلامك دكتور وليد، يعني احنا هسه already we spoke about the cognitive effects of citalopram. فيعني اكو مثل بالعراق يقول كانت عايزه التمت، يعني هو already عنده cognitive defect، فاحنا نضيف له citalopram حتى نضيف الكوجنيتيف ديفكتس، هذا غلط.
هذا الأمر الغريب، ما أحيانا تجد يعني أشياء متناقضة
نعم.
في بعض الكيس ريبورتس. هو أنا أستغرب بأنه بعض الزملاء يعني يقرأ كيس ريبورت ولا يعرف ما الفرق بين دبل بلايند ستدي، كنترولد ستدي، بلاسيبو كنترولد، 3 arm 2 arm، ومجرد يعني أنها نشرت في مجلة ما، مهما كانت هذه المجلة مرموقة، هي كيس ريبورت وهي لا تقول أكثر من أنه أنا فلان لاحظت ما يلي على هذه الحالة. وطبعا هو قد يعزوها بسبب أنه الدواء قد يكون فعليا مريض تحسن لأي سبب، لأنه أخذ عسل، لأنه شرب عصير رمان، لأنه ولكن يعني هذا قول بأنه هذا هو سبب التحسن. يعني نعلم بأنه في الدمنشيا هناك fluctuation،
نعم.
وأحيانا قد يكون كل التدهور كان بسبب وجود التهاب بالمسالك البولية، وبعد معالجته تحسن ولا علاقة لأي لا الستالوبرام وغيره. فبناء الممارسة على أساس حالة أو حالتين أو ملاحظة رآها أو سمعها أو قرأها، هذه ليست من الطب الجيد. يعني أنا أرى دكتور نزار معنا مجموعة من الأطباء المقيمين،
نعم.
وبالتالي يعني لا بأس أن يعني نوجه الأطباء المتدربين إلى كيفية استعمال الليتريتشر وقراءة البيبرز وما هي، وكيف تقرأ البيبر بالطريقة الصحيحة، ولك خبرة طويلة في هذا المجال.
طبعا الملاحظ حتى في الأطباء الجونيورز اللي عندي، مع الأسف الشديد طبعا أنه الاعتماد هو فقط على التكست بوكس، ومن يجي يناقشك يقول والله it is written this and that. الحقيقة هذا صح يعني you need textbooks, you have to read them very well, and this is a background knowledge, but at the same time you have to be careful, and you have to update yourself with a lot of journals, a lot of literature. Try to use recent literature, and also whenever you look at any journal, look at the impact factor of that journal. Some journals have very high impact factor, while others have a low impact factor, or have no impact factor at all. This is another point. And also, whenever you are looking at these literature or these articles, we have got papers, we have review articles, and we have meta-analysis. So the more the number of the papers that this study depended on, the more strong that paper is, or that review or that article is. And also remember that case reports are important, and they are accepted by many journals, but one case report is not enough. And when authors write books, they depend on the reviews and the meta-analysis and so on. Occasionally, they say there are some case reports talking about this and that. So always you start with the abstract, of course, and in the abstract you need the methodology. And if you want to be a good researcher, concentrate on the method that was used for the conduct of that paper. At the same time, remember, the conclusions are not always positive. There are sometimes there are negative conclusions. Again, this is acceptable, and you can depend on them. But I repeat, I don't want to that textbooks alone are not enough. You need to read journals, you need to read articles, you need to update yourself. And of course, remember one thing, and this is the last word that I say, today there is something called management of information. You cannot become a Superman and read everything. It is not possible. So really, you try to read things which are relevant to your specialty, and things which are which you can control and you can understand. And if you read a paper for the first time and you don't understand it, that doesn't mean that it's a difficult and complex paper. You can repeat reading it 2 or 3 times. Sometimes I read an article 10 times, believe me, and that is how I grasp it and I learn from it. And thank you very much.
أي سؤال من الزملاء الزميلات؟ شكرا جزيلا الأستاذ الدكتور سليمان نزار أمين من السليمانية في كردستان العراق على هذه المحاضرة الممتعة، وإلى اللقاء. لنا لقاء يوم الخميس مع الدكتور سداد في محاضرة اليوم العالمي للصحة النفسية.
شكرا، وتصبحوا على خير.
شكرا جزيلا.